This mini lecture is going to be on diabetic retinopathy and macular degeneration. Diabetic retinopathy is the leading cause of new adult blindness in the United States, and the prevalence is related to the duration and the type of diabetes. So if a patient has had type 1 diabetes for over 20 years, they most likely will get retinopathy, as well as over 60% of patients with type 2 diabetes. And there is two different types. There's the non-proliferative type as well as the proliferative type. With the non-proliferative, it is the initial manifestation of eye disease, and there is intraretinal vascular damage. There's dilation of the small vessels and the vascular closure leading to ischemia. In the proliferative, there's abnormal vascular proliferation, and that originates from the retina, and this can lead to blindness and involves neovascularization with retinal detachment and some vitreous hemorrhages. There are risks associated with getting diabetic neuropathy, so your risks are higher if the patient, if they're a smoker, if they have hypertension, if they have had renal failure related to the diabetes, or hyperlipidemia. Testing is helpful in identifying these risk factors. So when you're testing for diabetic retinopathy in someone who's over 10 years old and adults with type 1, they should have a comprehensive eye exam by an ophthalmologist completed every 5 years after the onset of diabetes. And with patients with type 2 diabetes, they should have a comprehensive eye exam shortly after diagnosis, and then yearly or more often if they do have retinopathy that is progressing. Women with pre-existing diabetes who are planning pregnancy need a comprehensive eye exam and counseling about the risks of the progression of retinopathy. So treatment for these patients is really going to be done by the retinal specialist and not by the nurse practitioner as far as when it comes to laser photocoagulation or any type of laser treatment or pan-retinal photocoagulation. One of the things you will be managing is that we need to make sure that they have very tight glycemic control, because that does prevent and delay many of the problems related to diabetes in general. So the presence of retinopathy is not a contraindication of the aspirin therapy for cardioprotection, and it does not increase the risk of retinal hemorrhage, so they may still take this if indicated, and then send them immediately to an ophthalmologist so that they can be followed on a regular basis. And you will be seeing them back in the office just for other issues related to diabetes and everything, but they will be referred to the eye specialist, and he will follow them and manage their retinopathy. And this is a photo of where you can see the vessels and the changes that occur in the eye from retinopathy. Next, we're looking at macular degeneration, and this is also called low vision. And it is a disease of the aging, and it's the leading cause of blindness in patients older than 60 years. Their central visual acuity is affected. Their vision cannot be corrected by corrective lenses, and they have a gradual vision loss. So there's wet versus dry macular degeneration. When you think of dry macular degeneration, it is characterized by a very slow, progressive atrophy and degeneration of the retina. After one eye develops the wet, which is a sudden distortion or loss of central vision, then they need to be referred to an ophthalmologist immediately, because after one eye develops it, the risk of the other eye increases by 40%. 90% with severe central vision loss have the wet age-related macular degeneration. So the dry is more of a benign clinical course. The macula is the most sensitive, and the central portion of the retina, a nerve-rich area essential for sight. And the degeneration occurs usually in the central vision in the fine detail perception. The patients, what they'll do is start complaining that they can't read right or at all. They may They may be able to still see facial details and read signs and carry out their ordinary daily visual activities, but they have difficulty with reading. So, as I said, this is a prompt referral, which is critical if they have wet and if there's a recent decline in the vision or if the vision is distorted. And the diagnosis for this will not be made by you as the practitioner, but it will be made by the ophthalmologist. They will do different testing. They'll do an Amsler grid to locate any macular blind spots and areas of distortion and wavy lines. They'll also do some other different contrast sensitivity testing, which obviously you're not going to be doing in the primary care. So referring them for ophthalmology, they'll be continue to be followed by them. And these patients really need to be advised that smoking cessation is necessary. They need to have improvement in the cardiovascular risk factors because the progression is worse when they're smoking or having cardiovascular issues. This is a good picture of someone who has macular degeneration. You can see the yellow round spots, which are also called drusen, Drusen, which are indicative of early macular degeneration. The clumps of pigment irregularly interspersed with deep pigmented areas of atrophy in the macula are more typical of a later phase of macular degeneration. So this gives you a good idea of what it might look like.